Brain is apparently still developing into a person's mid-20s. Is that true?
I won't say developing, but I would say the brain is a dynamic structure.
So do you think AI actually has a role in neurosurgery?
It's been tried, whether you call it brain transplant or the body transplant. I mean, it depends.
What exactly is a tumor?
Majority of these tumors affect the brain. If there are people watching, நீங்க வந்து cinema hero மாதிரி, the famous Muhammad Ali ended up with dementia towards the end of his life.
Yeah.
The brain is the seat of all sensation, but the poke a needle into the brain, but the brain will not feel pain.
Tumors that are malignant.
I don't agree with what you said. What you have to do is to remove the tumor as maximally as you can.
Hello everyone, I'm Arya Nepal and I'm here to start off this podcast with Dr. Sridhar, and he's a pioneer in neurosurgery. I don't have to speak much about him, and I have tons of questions in this field, about this field. So we're going to clear all of that because I'm sure if I have those questions, you'll also have those questions. So join us in this wonderful time, and yeah. Hi doctor, how are you doing?
How are you, Arya?
I'm doing very well. How are you?
I'm fine, thank you.
Thank you for giving me this opportunity, for asking you everything under the sun about neurosurgery.
Sure, and I'm delighted, and I will be delighted to answer all your questions, provided I know the answers to all of them. Because you know, the brain is such that sometimes we don't know everything about the brain.
Yeah. Okay, I'm gonna start us off with a small icebreaker. We're gonna do like a rapid fire question,
That scares me.
Yeah, just to get us all warmed up. So my first question is neurosurgery as dramatic as Grey's Anatomy?
I wish it were, and I wish I were like Derek Shepherd in Grey's Anatomy. But unfortunately, you know, life is different from what you see on the silver screen.
Yep.
Yes, it can be dramatic. It has a lot of drama in it, but it's also reality.
Yeah.
So there is a lot of drama in what we do, but it's also a lot of ground reality, truth, people's sufferings.
Yeah.
All that is involved, and therefore it's not all, you know, the starry things which you see in Grey's Anatomy. And I'm definitely not Derek Shepherd, McDreamy, but it's truly fantastic and very different from many other branches of medicine.
Yeah, of course. I myself had the opportunity of shadowing Dr. Sridhar, and it has been one of the best things I've done probably in my life. And we're going to get more into that. But before that, the brain is apparently still developing into a person's mid-20s. Is that true?
Okay, I won't say developing. But I would say the brain is a dynamic structure.
Okay.
If you look at it when the child is born and the child grows, if you look at weight-wise, it sort of gets its optimal weight by the time the child is about 2 years old, the development stage.
Yeah.
And then the weight matures by about the teenage.
Okay.
And then for a 60-year-old adult, the average weight would be about 1.5 kg.
Wow.
Having said that, that is only the weight, the outside structure. But what happens inside is that what you talk about development is that the development of the brain is related to the connections each nerve cell makes with another nerve cell.
Yeah.
And the more the number of connections, the better the brain works and therefore develops more. So it's like a child. If you see a child goes crawling everywhere, it picks up things, it wants to touch everything, it wants to put everything into its mouth.
Yeah.
Why? Because the child's brain wants to learn.
Yeah.
and it learns by looking, it learns by touching, feeling and tasting, because those are the basic feelings that one has. And as we grow, we can learn many things, and as we learn, our brain develops in the way you would say develop, because that's when we increase our intelligence, increase our knowledge and things like that. So I would say that the brain is at a constant stage of development all the time. But the 2 years after birth is crucial, because that sets the foundation for the rest of the life.
And when I was in university, my neuroscience professor used to often say neurons that fire together, wire together. Like, they're all up and about, and the child is always learning, and they have billions of neurons when they're just born.
Perfect.
But at the same time, I have a question, because tons of people assume stress is it's a different entity on its own. It doesn't affect the brain. But as far as what I've seen, with some of your patients, as maybe most of them, stress seems to be a very real aspect of the brain.
Stress, the emotion of stress, it's an emotion. The emotion of stress and anxiety comes from the brain, just like all other emotions. Whether you call it love, hate, greed, whatever it is, it all comes from the brain, and there are different parts of the brain which are involved in this, and therefore stress and anxiety is also an emotion which comes from the brain. It's a natural phenomenon to be anxious, especially when patients come to me. You mentioned naturally, because they've got a problem with the brain. Naturally, they're anxious because most people don't know much about the brain. But it is something which comes from the brain. It's not separate from the brain. People think, the heart is related to love, but that's such a myth. It's so stupid. But so if everybody says this on Valentine's Day, I love you, and touches their heart, but it's actually not the heart. It is the brain. So
we're going to go a little bit into your life as a neurosurgeon, ask you these really rapid questions, and you're going to answer them really quick.
Okay.
So what's the first thing you do as soon as you finish surgery?
Oh, I wash my hands, of course. But then I also stretch a bit and try to relax my mind, because when you're operating, it's full of adrenaline. It's a lot of you're there. It's like you finish a game of soccer or football, and then you're finished. So you generally want to get your mental state back to normal.
What's the longest surgery you've done?
I think the longest which I have done is about 14 hours.
No way. Oh my goodness.
But we take breaks in between. But it's 14 hours.
Wow. Okay. Really, I've been having this question. Do you ever Google symptoms yourself?
Do I ever Google symptoms? Of my own symptoms? No.
No?
Dr. Google knows a lot.
So you think
but
he's a doctor?
He also, because so many people consult him. Him or her, I don't know. I don't want to make it. So let me say, gender neutral. But I think Dr. Google also knows a lot of things which are not true. So you would have to be really knowledgeable to sieve through that. That is the whole problem with Dr. Google. So I don't use Dr. Google for myself.
Okay. What do surgeons talk about during surgery? Really curious.
I don't talk.
Really?
I am a terrible guy during surgery. I tell my people in the operating room, my anesthetists, my nurses, the floor nurses, the techs who are there, everybody, that I am like Spider-Man.
Oh, wow.
Meaning, I can hear, somebody breathe. I can feel somebody is moving. So things like that. So because when you're operating on a critical part of the brain, you are so focused, all your senses are heightened. It's at an adrenaline high. therefore, when your senses are all heightened, you can actually feel. I know somebody is moving behind me. I don't see it, but I know, and I say, stop moving.
Wow.
But because it is distracting.
Yeah.
Because surgery in the brain is now so precise.
Yeah.
We are precise to the sub-millimeter.
Wow.
So we can't make a mistake.
Yeah.
So I don't talk.
Okay, we're gonna ask you to share 2 truths about you and 1 lie about you. We're gonna guess what the truth and the lie is.
So you want me to say 3 things?
Yeah, but it has to be 2 truths about you and 1 has to be a lie.
Okay, I'm a sportsman.
Okay.
I love music and I am very affable, or I don't know whether that's true or that depends on the other person. I shouldn't be saying that. I love reading.
Oh my goodness. I feel like, okay, maybe the lie is that you're a sportsman.
Yeah, you got it.
Yeah, okay, awesome. Because I feel like the only sport you play is surgery.
Yeah.
But what is one thing you can't survive without?
Work.
Really? Oh, wow. Okay. A
I
week?
get migraine if I don't work.
Really? So then what do you do?
So I
over
tell my
weekends, I'm
guys, if you don't give me work to do,
Yeah.
you guys are going to have a bad day.
Oh, wow. Okay. If you could tell your 18-year-old self something from the future, what would you say?
Do the same things.
Yeah? Awesome. Okay. What's one area of that you would research on if you were given like a research free pass? Like nothing, no restriction whatsoever.
Can I make it 2?
Yeah, sure.
One is recovery from spinal cord injuries.
Okay. Wow.
The second is to find a treatment or a cure for a malignant brain tumor.
Yeah.
Because these are 2 things where currently we are having a lot of problems, and there's a lot of work which is being done, but we've still not reached any positive conclusion or result which will actually help patients.
Wow. As you know, just leading on to that question, as a neurosurgeon, do you think ever in the future, with how we're moving as a generation, brain transplants could ever be possible?
Sure.
Really?
Sure. I mean,
Wow.
it's been tried, whether you call it brain transplant or the body transplant. I mean, it depends.
Yeah.
The crux of the matter, see, I mean, in our mythology, Lord Ganesha had a brain transplant, had a head transplant.
I had no idea.
Yeah.
Okay.
Yeah. You don't know the story?
Nope.
Wild. So he wasn't born with an elephant's head.
Okay.
So he was born normally like a kid.
Okay.
And he was asked to guard Parvati's.
Okay, somewhere I've heard this.
Yeah,
Okay.
Parvati's, mansion, and then Shiva comes along,
Oh,
and
wow.
he says, "Sorry, I've been asked not to let anyone in." He says,
Okay,
"I'm
I
your father,
remember
move out of the way." He says, "I don't care.
Okay.
My mother told me this." So
Okay.
Shiva gets angry and cuts off his head.
Oh, wow.
So Parvati says, "What the hell? You cut off our son's head." So then Shiva realizes, what a stupid idiot I've been. And then he says, "I will get to the head of the first animal I cross." So he
Okay.
crosses an elephant, and then he, transplants the head onto Lord Ganesha.
Okay.
So that's how Ganesha has a elephant's head.
I had no idea.
That is mythology. But if you look at actually whether it is possible, it is possible.
Okay.
The only problem or stumbling block is how to connect the spinal cord. That is where people are still stuck.
Yeah.
But having said that, with the new AI things coming, and if you remember some of the villains, say maybe in Robocop or in Spider-Man, you have a chip which is kept inside the brain, and then the arms move. So maybe it's going to be possible. Who knows?
Yeah. No, I'm assuming like with so many nerve endings in the spinal cord, I don't know how
That's true. But then if you can bypass that,
Yeah.
and get the communication below, you've done.
Wow. So do you think AI actually has a role in neurosurgery? What do you feel?
Definitely, because AI is something which is all pervading. Though in the immediate current scenario, we are not using AI to the full potential of AI. AI has come into radiology, into diagnostics, but I'm sure that AI is going to play a major part in neurosurgery as well. We only don't know how and to what extent, but I'm sure it will, but mainly in diagnostics, in how we diagnose things, in looking at MRI images, things like that. It's definitely going to play much more of a role than it is currently. But beyond that, I'm not too sure, because actual surgery would have to be done by a person. Though AI can help in creating virtual realities for simulation and things like that, but not the actual treatment of the patient.
Wow. There's this, so Dr. Sridhar has, public who don't know, Dr. Sridhar has this frame in his room that says neurosurgeons can't afford to make mistakes. So I want to ask you more about that frame, because I see it follow you everywhere you go. Like, he's been through so many cities where he's practiced as a neurosurgeon, but I see this one frame follow you everywhere. So why do you feel, as compared to other surgeons, neurosurgery is just a field you can't make a mistake?
Okay, I'll answer this in two parts. One thing about that frame. Now, that frame has got some history.
Okay.
Professor B. Ramurthy was my mentor, teacher, uncle, pioneer neurosurgeon of the country.
Yeah.
Now, he brought that photograph. It's a photograph of a person doing a tightrope walk between two mountains.
Yeah.
And that was two mountains in the Alps. And he brought that back from Paris on one of his trips in 1960. And he had framed it and put it up in his room.
Okay.
And he had written below it in his handwriting the same thing. Neurosurgery is something where you can't afford to make a mistake.
Yeah.
And he used to make us read that out almost every day.
Wow.
The reason being, it is, in neurosurgery, see, all of us anybody can make a mistake. It's human to err. Anybody can make a mistake. But in neurosurgery, when you make a mistake, it is very visible. Because if you make a mistake, a person either gets paralyzed or loses function of something which is very discernible to everybody.
Yeah.
And that is why it is, even a small mistake is a major thing.
Yeah.
So you can't afford to do that. That is to keep reminding ourselves how critical the brain is.
Yeah.
We don't think about it in our everyday life, but that's how critical the brain is.
Wow. So what do you think is one thing that Dr. B. Ramurthy actually, as a mentor, shared with you that you still carry?
I think it's a 4-letter word.
Yeah?
It's called care, C-A-R-E. And he emphasized on the concept of caring for a patient. So he said, don't ever forget the word care.
Okay.
Because if you care for a patient, you'll do everything right.
Yeah.
I mean, it just covers all aspects of being a doctor in medicine. So the word care, he said, was the most important thing.
Yeah.
And I think that is something which I also try to tell everyone working with me, that thought of I should care.
Yeah.
If it is there, I think we will do wonders.
Yeah. No, and personally, I see that you definitely give that care from a wholesome perspective to the patient. Which brings me to this question. You speak multiple languages, as I've seen, and that shows that one amount of care for, like, just communicating in that dialect. So from where do you get that interest? Please tell us all the languages you speak.
Okay, I speak English, Tamil, Hindi, Bengali, Malayalam, a smattering of
Telugu
Kannada,
as well?
no, Telugu I mentioned.
Okay.
I speak Telugu quite well. Okay, Urdu is Hindi almost. So I speak a smattering of Arabic. That covers almost everything, I think.
Yep.
I love learning languages. The reason I am more interested now as a doctor, especially as a neurosurgeon, when patients come from different parts of the country and abroad, is that you put yourself in their situation.
Yeah.
You are going somewhere to meet a strange person in a strange land with strange language, with strange food. You are anxious because somebody has told you there is something wrong with your brain or your spine.
Yeah.
And you don't know what's going to happen. And if somebody talks to you in your language, how nice is that?
Yeah.
You feel at home.
Yeah.
And I think that's a basic connect that a doctor should make with the patient. Because at the end of the day, leave everything else aside. Between the doctor and the patient, it is a relationship of trust.
Yeah.
If the trust is not there, there is no relationship. So the relationship of trust has to be there if you are going to do high-end work like this in neurosurgery.
Yeah.
So I think this is just one small effort as a doctor that I can make to try and speak in that person. And you know what happens? They come in, very with a the face, the smiley face, which is the downward curve. And then you speak to just say hello in their language, and then it's a broad smile. And you won them over.
Yeah.
I mean, I think these small things are very important, and that is also part of care.
Yeah.
That's it.
And speaking on this care, something I've noticed very often with your patients, at least from shadowing you, is you go so against bed rest. Very contrary to what other doctors. India has this thing that if you're sick, you need bed rest. And you, as a neurosurgeon, you'd have done one of the most complicated surgeries, and you'd be like, get up and be up and about. Even with my dad, when you operated on a slip disc, up and about, like. And why do you think you kind of emphasize on that mobility?
Our body is a machine. Okay? End of the day. If you don't work a machine, this is the example I give all my patients. Or a machine otlena, it will rust.
Yeah.
If you keep a door shut for a long time, it won't open, it will creak. So why do you think if you keep lying down and don't give your body work, it's going to function very well? It's not going to function well. And actually now there is scientific proof that if you don't exercise or work your muscles, they will weaken. They will go into disuse. Therefore, it is best to get up and start working your body and mind.
Okay.
So I think it is very, very important. I think it's an old concept. I mean, when we were young, we used to tell people lie down for 10 days, lie down for 2 weeks. And I think it's a wrong concept. And I think people are happy to get up and about. Yes, they are a little worried, can I get up?
Yeah.
But once they get up and about, you can see the change in how positive they become.
Yeah.
Imagine lying down looking at a ceiling.
He says this to everyone, that exact sentence. Oh my goodness, he says it to every patient. So now I feel like one. But talking about care and like mobility and just being active, recently, there's been this whole hype around these quick fix medications. And often with that, I've seen your approach is more so you don't hinder yourself from telling your patient, saying just get up and walk. If it's anything related to medication, if you can avoid as much as you can chemically, you might as well avoid that and go for a walk or take care of your body and sleep well. Why do you think it's important to, stick to that conservative approach as opposed to, actually taking these quick fix meds?
I think it's my psyche. I'm very aggressive at surgery.
Okay.
But I'm completely the opposite when it comes to quick fix. Because I feel anything which you do quick fix is not going to work in the long term. It may give you an immediate gratification, but it's not going to work for you in the long term. So that's my belief. It works for me and my patients. So if you are going to be up and about, if you're going to be looking after yourself, I think it is very important. And this is something which from personal experience I'm still learning. We used to work, all the time. Sometimes not looking after ourselves. And I'm telling you, at some point of time, as you grow older, I always think when you're young, you're invincible. That's a thought that all young people have. I had that. We all thought that. But as you grow older, it catches up.
Okay.
And then you realize, oh my God, I should not have done that. So I think it is very important that each person looks after their health.
Yeah.
Because if you are healthy, you can do that much more. If you are not going to be healthy, you're going to be out of business, out of circulation for a long time.
Yeah.
So I think health is perhaps the most important thing. Health does not mean, having a six-pack.
Yeah.
Unfortunately, that is also a myth, which is, it's a fad.
Yeah.
Or, I've got a six-pack, I'm healthy. No. Healthy means that you are able to live through every day comfortably, happily. You put your head down on the pillow and you're off to sleep. You sleep a good 6 to 8 hours, get up refreshed, ready to get on the next day.
Yeah.
And that you can do only if you are healthy. Eat healthy, be physically active. You don't have to do 10,000 steps. That's another myth if you ask me. But I think you should be healthy. You should be able to do what you want to do.
Yeah.
That's my philosophy.
Coming to some neurosurgical options that we have now as compared to before, a question I had was, we see a lot of patients with trigeminal neuralgia. So in those kind of patients, and something that you're passionate about as well, when it comes to so many conferences, I've seen that you touch on this topic. So why do you think that now, MVD is so popular? What did we not have back then? Microvascular decompression. What did we not have back then that we have now? That is the go-to for this.
Okay. Trigeminal neuralgia has always been there.
Yeah.
What has changed? Number one, MRIs.
Okay.
So the MRI scan allows us to see the brain beautifully. In high resolution, you can see almost everything in an MRI, in a properly done MRI. And that tells us a lot, because trigeminal neuralgia means you have to look at what is irritating the nerve, which is taking sensation from your face. And for that, you require a high resolution MRI. You require somebody who knows what is happening to see it, and that's available today. The second thing is that we now have more knowledge because of the technology that we use in the operating room. We use something called the operating microscope, which magnifies things to 15 times or so, and allows us to operate in a very, very precise manner. You see the gap, what you have when you operate between, by the way, I'm digressing a little bit. Unlike other structures, when you operate on the body, other places in the abdomen or something, you can pull, you can push.
Yeah.
You can't pull and push the brain. That's a disaster. So you have to operate through the gaps between the bone and the brain, or between the folds of the brain. Now those gaps are sub-millimeter.
Wow.
And sometimes you would have to do this surgery about 6 centimeters deep through a gap of about 2 millimeters. Okay? So imagine you have a pair of chopsticks.
Yeah.
And you want to pick up a small chocolate. You know, we used to get those gems before.
Yeah.
You have to pick up that. It's one of it at the bottom of a water bottle.
Wow.
Imagine wanting to do that. That's just how it is. So we have now the technology to do that. We have the instrumentation to do that. And therefore, because we've got the instrumentation and the technology, we start using that and we become good at it.
Okay.
The second point is we now know, because of years of experience, this surgery which you spoke about, microvascular decompression, was brought in to the neurosurgical field in the 1960s. It was initially rubbished and then got accepted in the 1980s.
Wow.
But now we know, it is now 20 plus 25, it's almost 50 years. We know that it works.
Okay.
We know that it is one thing which will give the patient very good relief from a pain which can make a person try to commit suicide.
Wow.
And that relief is phenomenal. So imagine that you get relief by a surgery of a pain which is
Unending.
because of which you can try and take your life. I mean,
Yeah.
that is the whole point, how neurosurgery has changed. And this is just one example.
Yeah.
So it is a lot of technological advancement which has happened in the field of neurosurgery, which has helped us understand the limit to which we can go.
Okay. Wow. And that brings me for another surgical procedure as well, which is not really surgical, but can you speak more on deep brain stimulation for seizures? Because recently I saw you.
No, that was
that.
we recently saw the patient who we did that for a movement disorder.
Okay.
You saw another patient for whom we did surgery for seizures or epilepsy.
Yeah.
So deep brain stimulation is, if you want to say it colloquially, it's like the brain pacemaker. Okay? So in the brain, especially for patients with Parkinson's, it is the shaking disease where your hand can shake like this, and your whole system slows down. That is Parkinson's. And that happens because one part of your brain is not producing a chemical.
Yeah.
Now, how do you make that brain produce the chemical? A long time back, not long so long, but in the 1960s, actually Madras, or how it was called, Chennai was called, was the center point place for surgery for Parkinson, because we used to do what is called stereotactic surgery for that, where a small part of the brain would be destroyed. Very millimeter point of the brain would be destroyed to make the other part of the brain work better.
Oh wow.
But now, again, when medicines don't work, so now the technology has worked so that you can put a small electrode into the non-functioning part of the brain and then stimulate it to function. So that the production of the chemical is increased in the brain, and therefore the patient's symptoms go away.
Wow.
It is technology and it's wonderful.
Yeah.
You can see on the operating table that the patient's tremor, the patient is doing this, And when you do the deep brain stimulation, put the electrode in and you switch it on, it stops.
Wow. Yeah.
It's as dramatic as that.
Yeah.
You spoke about drama,
Yeah.
and this is dramatic. So these are things which technology allows us. Epilepsy, you said.
Mm-hmm.
Now we can do surgery for epilepsy, where especially when you see children who are suffering from very regular seizures,
Okay.
they are on 3 drugs, 4 drugs, and they suffer, the parents suffer. Surgery is an option which is very viable. There are various types of surgeries now which we now know which will help these children. Not only stop their seizures, but we can reduce the medication. It is not only stopping the seizures, but when you stop seizures, the brain development improves.
Wow. Talking on the topic of seizures, actually, I had this question for a very long time. I don't know if you remember, but I've known him, I've known Dr. Sridhar all my life. And I remember at a very young age, I saw someone seizing. And then in Indian culture, there's this culture of giving keys or like neem leaves and all of that. Just something didn't feel right. And I gave him a call and I said, I don't know what to do. And he was like, just turn the patient over to this side. And I thought about it about last week, and I just wanted to ask you, is it a myth or does it actually work? Like, what is the whole facade of neem leaves and keys? Does it actually help? And if it does help, then is that right? Or if it doesn't help, what should a person actually do if they see someone having a seizure?
To answer that question, let me start by explaining to everybody listening what exactly is a seizure or epilepsy. Most people don't know that our brain works on electricity, just like the wires and lights which you see here.
Yeah.
It is all electrical wires with its own insulation.
Yeah.
The only thing is that the current which is passing through is in microvolts. So if this is a nerve, so there is electricity passing here, and then if I want to pass on a message to that, I have these endings which are like fingers which come here, but the message doesn't get passed by electricity. But what happens is, as soon as it reaches here, it releases chemicals which then pass on to this nerve, and then again the microvolt electricity goes on. And that's a communication. And this, I tell you, is a communication wonder. It is electrical energy getting converted to chemical energy, which is again then getting converted to electrical energy. And that's how our brain works. And different types of chemicals are there, some which stop the electrical energy, the electricity from passing on, some which allow the electricity to pass on. So there is a system whereby if I want to move my hand, my brain sends the signal down to my hand, making my hand move. It doesn't go anywhere else in the brain. Imagine that there is a short circuit in my brain, meaning the 2 wires touch each other and there is a spark. So if there is a spark, what happens? The electrical disturbance spreads without being channelized, and therefore it can go anywhere in the brain. So if it goes and spreads everywhere in the brain, it's an uncontrolled movement. And that is what we see as fits, seizures or epilepsy. Therefore, epilepsy or fits is an uncontrolled electrical activity of the brain. A lot of people think it's a disease. If you ask me, it's not a disease. It is just uncontrolled activity of the brain. That's all it is. And therefore, medicines can control this uncontrolled activity. Now, the question of giving keys, as of now, there is no scientific proof that giving keys will stop a seizure. So, being a man of science, I think doesn't work. But you should also understand that our brain, the whole earth, there is a lot to do with electromagnetic activity which goes on.
Yeah.
So and imagine the keys which are specified to give are iron keys. They are not stainless steel keys. You can't give the modern car key and say, "Na savi kutte."
Yeah.
They're supposed to be iron keys. So probably there is something to do with the ferromagnetic activity which gets transmitted to these iron keys, and maybe that is the thought which happened in those days. But currently, I think we don't get iron keys. We have only stainless steel keys, or more often we have only keys which work on the radio frequency pulse, like the car keys.
Yeah.
So giving a key is, I think, it's not the right thing anymore.
Yeah.
What you should do, make sure that the person who is having the fit is able to breathe.
Okay.
If he's wearing a tie like me, remove the tie. Turn the patient over to one side so that if there is a froth or saliva or something like that, it comes out. And give the person space. Don't please give na soda kudukren, na tea kudukren. Adala panna kudad. Fits stop by themselves. If they don't stop, or if it comes continuously all the time, immediately call for an ambulance and shift to a hospital. Because there is nothing else that you can do at your home or on the roadside.
Yeah.
So 2 messages. One is loosen the clothing, let the person breathe. Second message, do not give soda or tea. It's not going to help the person.
Yeah.
Third message, turn the patient to one side so that any saliva or frothing or anything which comes in the mouth, which generally comes out of the mouth onto the outside rather than going to the lungs. So that's what we try to do and teach nowadays.
Thanks for busting that myth so people know how to handle this. Recently, when I just graduated from university, one of the things my professor was talking a lot about was these headbutting scenes that we see in movies, where they completely headbutt. Heroes have this concept of headbutting the villain, and then they seem completely normal after that. But ever since he spoke about it in the lecture, I cannot see even soccer where they're like headbutting, because there's so much it could cause like a TBI, like a traumatic brain injury, or there could be concussions, and all of that. In those kind of situations, what do what kind of sports do you recommend as a neurosurgeon for people to
if
play?
You look at American soccer, is what you're talking about.
Yeah.
They always wear helmets. They don't headbutt without helmets.
Okay.
Boxing is one thing where you get hit on the head and you are asking for it.
Yeah.
But many boxers, including the famous Muhammad Ali, ended up with dementia towards the end of his life, which was a result of the boxing.
Yeah.
Which is the result of continuous blows to the head.
Yeah.
It's all very nice when you're playing the game, but every fall, every hit on the head has its consequence. So if there are people watching, நீங்க வந்து சினிமா ஹீரோ மாதிரி தலையில இடிச்சு சண்டை போடுறது வந்து நல்லது கிடையாது உங்க மூளைக்கு. மற்றவங்க மூளை இருந்தா பார்த்துக்கலாம், இல்லைன்னா விட்டுடுங்க. பட் பண்றது நல்லது கிடையாது. You also have, if you look at football, when two players collide, professional football, 2 players collide, and a player falls down, the medical team always rushes.
Yeah.
And there is always a check to look at concussion. And if they feel concussion, the player is carried off.
Okay.
And I think there are rules which are very strict in professional games, which are now. So any hit on the head is a potential danger, and continuous hits on the head can result in problems to the brain. So it is not a good thing which they show in cinema, but it's cinema.
Yeah.
Real.
Yeah. No, and that's what it's it's quite, when we look at it from a scientific perspective, I'm like, oh my goodness, he lost so many neurons. And then after that, I'm like, it's so common in Hollywood or Bollywood movies. What do you think, if you could say something to people who had these, these lines written, the screenplay written, would you change it?
See, if you actually look at all that in a very scientific manner, the movie would be boring. It would be a big flop.
Yeah.
I remember once I was in the UK when there was a big Tamil movie released. So we went to see it. But then they have got such censorship things that all fight scenes were censored and taken off. We walked out half of the movie because there was no point seeing the movie.
Oh.
So, I mean, if you look at Indian movies, the fights, the dance, that's what makes the movie. And the song, dance and song, that's what makes the movie.
Yeah.
So, if you don't have fight sequences, imagine.
Yeah.
What a boring movie that would be. But having said that, it is important for public to realize that that is cinema. There are actually people are not doing it to each other.
Yeah.
Isn't it?
Yeah.
So I think that is important.
Yeah. Talking about surgery, when it comes to neurosurgery, what exactly is a tumor? Like when people say brain tumor, what are the symptoms of it? When is surgery necessary for a tumor? Some tumors, do they need to be removed? Do people just continue to live life normally? Speak to us more about what a brain tumor is and when surgery is needed.
Okay. A brain tumor, any tumor is an extra growth. It can happen anywhere in the body. So when you talk about a brain tumor, it is a tumor which actually it happens inside the skull. I would put it that way. Because inside the skull is the brain.
Yeah.
And majority of these tumors affect the brain. They may be inside the brain or they may be outside the brain and pressing on the brain. So extra growths which occur are called tumors. Now brain tumors are different from other tumors anywhere else in the body in that these tumors, even if they are cancerous, don't go anywhere else. They don't spread to other parts of the body. The other parts of the body, say a kidney tumor or a stomach tumor, can go to different parts of the body.
Okay.
But these tumors don't spread. So, like all other places, these tumors also can be either benign, with what we say, which means non-cancerous, or it can be cancerous or malignant brain tumors. So both are seen reasonably commonly, and the treatment for either of these, if there is an extra growth, the first and foremost treatment is to remove the growth.
Okay.
Why must you remove it is the next question. Because when the skull is a fixed volume, see, the skull is like a closed box. It's like a fixed volume, and then in that you have the brain, you have got the blood vessels, you've got the fluid of the brain, everything inside. So there is no space for anything more. So if anything more has to grow and occupy the space, it will start pressing the normal brain.
Okay.
And therefore patient will start having problems. So patient can have problems of either weakness of the limbs or difficulty in speech. The patient can have memory problems, problems of vision, hearing problems, problems of balance, depending on where the tumor is. So because the tumor presses on the normal brain, you can't have that, and therefore the first treatment for any brain tumor is surgery. And surgery nowadays for a brain tumor is reasonably simple and carries a risk of not more than 2 to 3%, which is less risk than traveling on a highway. So these tumors have to be removed for that, because the second point is not only do you remove the pressure on the brain, but then you can also get to know what type of tumor it is. Because once you know whether it is non-cancerous or cancerous, then you can decide whether the patient requires some other treatment or not. Even in cancerous tumors, there are good cancers and bad cancers. So it's a whole gamut and spectrum of tumors that we see, and the first thing therefore to do is to remove the tumor.
Okay. And when it comes to tumors that are malignant, when we see like a tumor like a glioma or something like that, how do you exactly navigate that? Because even removing it doesn't really promise much. So in those kind of situations,
I don't agree with what you said.
You think so?
Yeah.
Okay. I
don't agree.
I can agree to disagree.
Yeah. That's where my philosophy of life comes in.
Yeah.
I think a glioma is a malignant brain tumor. And I just said that even in malignant brain tumors, there are different types and grades. So you can have a glioma which is a good glioma. You can have a glioma which is a not so good glioma.
Okay.
So what you have to do is to remove the tumor as maximally as you can.
Okay.
Now the problem with gliomas is that they will come back because we still have not found cure for a glioma.
Yeah.
So if you catch them very early, and if they are localized to one part and we are able to remove it totally, I can give a good sense of, tell the patient that, yeah, you're going to do well.
Okay.
But I cannot guarantee that. But there are patients whom we have operated who are doing well for 15 years, 20 years.
Okay.
But there are people with some tumors which come back maybe in a year's time, year and a half.
Yeah.
So it depends on the biology of the tumor.
Okay.
And this is something which we have not been able to conquer yet.
Yeah.
And that's why I said, if you're going to give me unlimited amounts of money, so this is going to be one of the places where I would like to put that money into,
Research.
to look at research into gliomas. And a lot is going on. There are a lot of clinical trials with new types of medications and things like that. Targeted therapies are being tried, but still we have not reached there. But that does not mean we should be nihilistic about treatment of gliomas, because it's a 70% chance that a brain tumor, if you remove it, the patient is going to be well and live a good life for a good number of years. It's the 30% which we can't say.
Okay. And I've heard of like these awake brain surgeries. Why do you think the patients have to be awake, and what surgeries are these that
Okay, you see,
are awake?
Why do we have them awake? And the next question is, how can you have the person awake when you're operating on the brain? My God.
Yeah.
So there are many channels which have been showcasing this as though it's the first time it's been done. No, it's not. It's been there for a long time. The thing is, when you do brain surgery, the first thing is do no harm. Which means that you shouldn't make a good patient paralyzed.
Okay.
So if the tumor is in a place which controls the hand function or the leg function or the person's speech, or maybe the guy is an accountant and he has to do calculations, or maybe the person is a musician and therefore he has to have good control and fine movements of his hands. We have to preserve that.
Yeah.
Because what is important now is the quality of life of the person. So we have to preserve function. And quality of life of the patient is perhaps the most important thing currently in neurosurgery. It's no point saying I'm a great surgeon if I'm not able to give a good quality of life to the patient I'm operating on. And therefore, if I have a patient with a tumor which is in or near, say, the language area of the brain or the hand function of the brain, What I do is, when I'm removing the tumor, I keep the patient awake and I ask him to move his hands. What better way to do that?
Okay.
So I know that I'm not affecting him. Of course, there's a lot of technology involved in that. There's a lot of monitoring. There's a lot of the anesthesia drugs evolved in such a way that we are able to titrate them and do that such that the patients don't have any pain and all that. But the very, very interesting fact, which I'm not sure whether you know, the brain is the seat of all sensation, but the pain cannot be felt by the brain. If you can poke a needle into the brain, the brain will not feel pain.
Yeah.
And that is what helps us.
Yeah.
The skin, everything feels pain, but the brain itself does not feel pain.
Yeah.
So that allows us to do awake brain surgery. Yeah. And that is something which has helped huge number of patients and helped us help those patients by removing those tumors which are in critical areas.
Yeah. And when it comes to, surgery, what is the difference between, I'm sure a lot of people have this question, what is the difference between the spine and the spinal cord? Because when it comes to back pain, people automatically assume and go to an ortho because they feel like it's a safer option than immediately thinking it's neurosurgical. So what is the difference?
Let me tell you this. It is the difference between the skull and the brain.
Yeah.
The skull is a thick bone which protects the brain. The brain is inside the skull.
Yeah.
Similarly, the spine has two functions. The spine carries the weight of the body right through. And then the weight of the body goes to the hips and then the legs. Inside the spine, there is a ring. And through that ring goes the spinal cord, which is the extension of the brain, from which nerves go to every part of the body.
Yeah.
And therefore, you cannot separate the spine and the spinal cord, because inside the spine lies the spinal cord and the nerves. Back pain and other pains and other problems related to the spine are such that most of them are caused by a problem of the bony spine, but which has its effect on the spinal cord and the nerves. So what you're asking is a very tricky thing. Neurosurgeons are trained to deal with this right from their training period.
Okay.
But now you have a class of people called spine surgeons who are also trained. But generally, neurosurgeons more often deal with these problems like back pain. And back pain is something which everybody has nowadays because of improper posture, which is the most critical thing nowadays.
Yeah.
Ergonomics in office chairs, the way you sit, the way you stand, all that has its effects on the back and the spine. Therefore, what happens is that because you don't sit properly, it creates a strain on the muscles, and that creates a problem for the nerves as well.
Yeah.
So that's about the spine.
Wow. Everyone speaks about this golden hour when it comes to neurosurgery. What exactly is that? I have no idea what that is. I've heard of it colloquially, but
everybody says golden hour. The thing to emphasize rather is that time is brain.
Yeah.
Meaning that if there is a problem with the brain, you cannot afford to lose time. The faster you do something, the better is the recovery. That is the essence. So people thought, if you say golden hour, it's very good. But now what I say it is platinum minutes and diamond seconds.
Wow.
So each second counts, because say for example, if the blood flow to the brain is stopped, say in a stroke.
Yeah.
What happens in a stroke or a paralysis attack is that the blood flow to a particular part of the brain doesn't happen properly. every second that is lost, 30,000 brain cells die.
Wow.
How many? 30,000.
Wow.
So imagine in 1 second of blood not going to the brain, 30,000 brain cells die.
Yeah.
Imagine what will happen in 1 hour.
Yeah.
I mean, I can't even do the mental maths.
Yeah.
So the idea is, including even in a head injury.
Yeah.
Even in a head injury, the minute there is a head injury patient with an injury to the head, the faster the patient is transported to a hospital where he can receive proper treatment, the better are his chances for recovery. So also in a paralysis attack. Now, of course, in a paralysis attack, we have the wherewithal to reverse the paralysis. But the patients must reach a hospital which can do that in the shortest period of time. So I don't define the time by saying 1 hour, 2 hours, 3 hours, because what happens is patients will, the common thing is to say, okay, I've got 2 hours, okay, let me see. The point is, no, every second matters.
Yeah.
So every second matters. And the same thing, even when you're talking about a brain tumor. A brain tumor where a patient has got, say, the vision is coming down. The longer you delay the surgery, the more delayed and lesser will be the recovery. So it goes for all aspects of dealing with the brain or spinal cord, that the faster the patient receives treatment, the better is the recovery.
Okay. And when it comes to that question with stroke, I've seen a lot of people don't know the difference between a stroke and a heart attack. So can you just elaborate for the general public?
So most people think a stroke is a heart attack. When we say stroke, we mean a brain attack. So nowadays I start using the words brain attack.
Yeah.
Because like a heart attack, you have a brain attack. So just like in a heart attack, the blood flow to the heart is stopped. Similarly, in a brain attack, blood flow to the brain is stopped.
Yeah.
That's the difference.
Yeah, as simple as that.
As simple as
everyone knows what's the difference between a stroke and a heart attack. I had a question when it comes to headaches. Is it supposed to be something really dangerous? Because some headaches can be very minimal, some headaches can be very painful, and some of them are migraines as well. What exactly is dangerous about it?
So I think it was George Bernard Shaw, the very great English author, who said there's not one person alive on earth who has not suffered a headache at some point of time.
Yeah.
Headache is pain in the head, as simple as that.
Yeah.
90% of headaches are simple headaches, meaning it can be because of a bad tooth, it can be because you don't wear glasses when you need to wear glasses, it can be because you got a bad cold, it can be just because you got a fever, it can be as simple things as anemia, or what's the most common cause of headache nowadays? Stress and anxiety.
Yeah.
So if you take all these away, you are left with a 10% of all the headaches that you see. Now these 10% of headaches are the actual headaches which require specialist treatment.
Okay.
So it can be, say, a vascular headache like you say migraine, or it can be even more serious headaches. For example, it can be caused by a brain tumor.
Okay.
Now, one very, very important aspect of headache is that if a headache comes on suddenly, anybody who has a sudden severe headache, never like before, இந்த மாதிரி தலைவலி வந்ததே கிடையாது, எனக்கு ரெகுலரா தலைவலி வரும், ஆனா இந்த மாதிரி தலைவலி வந்தது கிடையாது. Like a bolt out of the blue. Anybody says these things, it is probably a bleeding in the brain, or rather, we would have to rule out a bleeding in the brain.
Wow.
And that is something which is another message which I would like to tell the people seeing or listening to this, because it's often missed.
Yeah.
And then more problems happen. So a headache which comes suddenly, never before, different in character, go visit a neurospecialist. You must.
And is this related to like dizziness as well, or just headaches?
Just headaches.
Okay.
Similarly, if a headache doesn't go away with normal medicines, go visit a specialist. So I think these are the circumstances when you must actually take notice that your headache may be something more.
Yeah.
And then go to a specialist and then get it investigated, treated. Now, these headaches may be accompanied by other symptoms, like you mentioned, dizziness. Some people may have dizziness, some people may have vomiting, some people may have blurring vision. Now, or ringing in the ear, or an imbalance. So there are various symptoms which can happen depending on why the headache is happening and which part of the brain probably is involved in the reason why the headache has come. So you have to look at it as a composite way before you actually treat the patient. Now, of course, with the availability of CT scans and MRIs everywhere, it's much simpler.
Yeah.
And diagnosis is faster.
And just a small follow-up to that, again, people don't know the difference between why they need a CT and why they need an MRI.
Okay, and the other thing, the safety of this. A CT scan is like a big X-ray machine. It uses rays and it has radiation. But the amount of radiation you get from a CT scan nowadays in the new machines is less than what you would get in an X-ray. Much less. An MRI does not use radiation. It uses magnetism. Therefore, the magnets work on the hydrogen ions in your body to get images. And therefore, there is no radiation at all. And therefore, an MRI is very, very safe. However, a CT scan is better for certain clinical problems, while an MRI is better for certain clinical problems.
Okay. Is there a time limit on neurosurgery when it comes to age? Like, what's the youngest? What's the oldest? Is there
You say age limit?
Yeah, age limit.
Or are you asking, is there a time limit after which you should not be operating?
Yeah, both actually. Because like some people assume, like, you know, as we heard in like this Tamil, phrase that says if you open the skull, that's it, your life is not guaranteed. So when it comes to that, what is that time limit? Like, is it like 65 age limit? It's the same kind of the same thing. So what exactly?
Are you asking for the patient or for the doctor?
For the patient. For the patient,
okay.
For sure.
If you look at neurosurgery, we can operate on newborns, and we have.
Newborns as in you mean like months or?
I'm saying days.
Oh wow, okay.
Days, because there are congenital problems. The child is born with problems which have to be corrected as soon as possible, otherwise the child can have major issues.
Oh wow.
So
okay.
we sometimes have, even on preterm babies who have been delivered, who have a problem, we have operated. So that's a little tricky, but it can be done nowadays because of, again, technology, because anesthesia is so good. If you ask us, what about senior citizens? How old? What is the bar on age? After this age, no, you should not operate. If you ask me age, there is no bar.
Okay.
What limits us from operating on a patient is the patient's medical fitness for undergoing surgery. So whether a person can take anesthesia and the stress of surgery.
But then when it comes to like dementia, Alzheimer's or anything like that, is that also considered under medical fitness or?
No, dementia or Alzheimer's is not considered under medical fitness.
Okay.
But if a patient has got Alzheimer's, why would you operate? You would need to be operating on the person for something where actually it's going to make a difference in their life.
Okay, yeah.
Now the point is, the person has to be medically fit, meaning should be able to undergo anesthesia. Now I have seen 50-year-olds and 45-year-olds who are bad candidates for anesthesia.
Okay.
And I have operated on even 87-year-olds
Wow.
who are good candidates.
Okay.
And sometimes the problem, maybe the patient is having a bad, painful condition or something, and the patient tells us, I don't care if I die, but I don't want to live with this pain.
Okay.
So sometimes surgery is done with high risk, but with consent from the patient and their family. So in short, there is no age limit for surgery.
Okay.
Okay? It doesn't mean, oh, vayasaiduche, onnu panna vendam. I mean, I hear this statement very often.
Yeah.
And I feel like asking the patient's relatives, if you had the same problem, would you leave yourself just like that? I mean, how can you say that to your family member?
Yeah.
Vayasaiduche apdiye irukattum. I mean, that's not right.
Yeah.
So I think current scenario, there is no age on which you can or cannot operate.
Okay.
There has to be medical fitness.
Okay. And just touching on...
And you spoke about this kaparathula kai vecha.
I heard about it in Tamil,
saying,
but...
that talala kai vecha avladhaan aalu.
Yeah.
Meaning if you touch the head, the guy is gone.
Yeah.
This is absolutely not true. I mean, this comes, I'm going to digress a little bit.
Okay.
This comes from an old, again, a mythological story.
Okay.
I think there was a demon called Bhimasara. I think so.
No idea.
Who prayed to one of the gods and got a boon,
Okay.
saying that anything I touch with my hand will turn to ashes.
Sounds like the Midas story with gold.
No, that is gold.
Okay.
This is not gold, this is the other way.
Okay.
It turns to ashes.
Okay.
So he went around touching everybody, his enemies. He even chased Lord Shiva, saying, I'm going to, turn you to ash. Imagine.
Wow.
So Shiva went to Vishnu and said, do something. So Vishnu transformed himself into a beautiful damsel called Mohini.
Beautiful damsel.
Called Mohini.
Okay.
And he went in front of this demon and, he basically, Mohini started seducing him with dance and told him, I'm sure there was alcohol involved as well, and told him, okay, you must do every step that I do, you should be able to do. So she danced and then he danced and then this thing, and finally one step she did where she placed her hand on her own head.
Oh.
So this guy did the same thing and put his hand on his head and then he turned to ash.
Okay.
So the thing is, tala kai vecha, you're gone. But that's not true.
Yeah.
Yes, 50 years ago, neurosurgery, the risk and the problem rate after neurosurgery or brain surgery, spine surgery used to be as high as 15-20%. The last 1 decade with technology, with the sort of precise and safe neurosurgery that we have, not only in theaters, not the surgery, the anesthesia is so safe. We do monitoring, we can monitor every nerve of the brain.
Wow.
The monitoring which happens after surgery in the ICU, it's all so fantastic that the risks have come down in most neurosurgeries to about 2%, which is like having an appendix out.
Yeah.
Or a gallbladder. So that is the safety now that we have in neurosurgery. So people don't have to be scared when somebody tells them you need a brain or a spine surgery. Yeah, of course you'll be anxious. but you don't have to avoid the surgery just because you're scared.
We'll come to our final question here, and something I was very curious about is, contrary to Western culture and Indian culture, the families are very involved with the whole concept of if a patient
that's good
is having
and bad.
neurosurgery. So in those kind of situations, and plus it could be daunting, they have like a full team as well, that you have a physiotherapist, you have a neurologist, you have a psychologist. Why do you think, first of all, is it important for families to be involved when it comes to a neurosurgery? What's the pro and the con?
Okay, I'll answer that question first.
Yeah.
Indian society, or rather I would say Eastern society, is very family oriented.
Yeah.
I mean, Tamil la 4 பேர் என்ன சொல்லுவா? That's the usual thing you hear. பக்கத்து வீட்ல சொன்னாங்க. Generally, families live together. Families depend on each other. You don't go outside the family to seek any help. You get it within the family.
Yeah.
So when a patient comes, generally I would have at least 3 or 4 people, family members coming first. Then you would have to talk to them, and then maybe you would have more coming in. Then you would have to talk to them. The emotional support that our patients get from their families is so good that they feel safe. This is missing in the Western population, where often the patient is left to fend for himself or herself.
Yeah.
And then you have the counselors and this and that, and then that is hyped upon.
Yeah.
But here is the family who does a lot of that. That's the good part. The bad part is you see the whole family coming in after the surgery in a room, which I don't like, because this is a major surgery.
Yeah.
And you would want the patient not to be crowded upon. I don't like the chance of an infection.
Yeah.
So I don't like that part.
And you're very strict about it.
I'm very strict about it, because end of the day, I am responsible for the patient, and I'm very strict about it, and I keep trying to tell patients that, and their relatives, that please keep family and friends away. This is not a family and friends affair.
Yeah.
This is the immediate family, 1 or 2 people only. But that's how our society is.
Yeah.
Now, hospital admit aana yarume vandu paakala.
Yeah.
I mean, people expect that when I'm admitted in hospital and I'm ill, 4 பேர் வந்து பாப்பாங்க. That's the way our society is, and you can't change that.
Yeah.
So you have to sort of live with it, and you have to work around it, but I think it is good for the patient. As far as what you said about
the multidisciplinary
approach, I believe in that concept very much, because I think with the current boom in knowledge in different fields, one person cannot know everything.
Because there's a lot of stigma when it comes to psychology, like psychological therapy or even physiotherapy. Because people think the latter, physiotherapy, doesn't work. They're like, oh, surgery is over. Or they're like, therapy, I'm fine mentally. Why should I be considered?
So that's the other reason. So when you tell people that we have a team, I call it integrated neurocare, where everybody's work is entwined in the next person's work, and we work together for the patient. And when you do that, people accept it. I don't just write off the patient and say, go see the psychologist for therapy. No, I sit with the therapist. We have sessions together. We call them in with the therapist there and say, see, this is where you have improved, this is where you need to improve, and this is why you need to work hard on it. If you don't, you won't improve. So I think this is a very important concept, where sitting by oneself as an individual, you can do that much, but sitting with a team where you have a multidisciplinary approach and integrated care, you can do very much more.
Wow. Okay, we're going to end off with this really quick rapid fire where you just say the first word that comes to your mind the moment I say this one word.
Okay.
Okay, it's very quick.
All right.
No sentences, just one word.
Okay.
Neurosurgery.
Can I use a phrase?
No, just a word.
Just a word?
Yeah.
Okay.
Neurosurgery.
Precise.
Slip disc.
Pain.
Prefrontal cortex.
Thinking.
Anesthesia.
Sleep.
Patients.
Patience or patients?
People patients. People who are
Care.
patients. Rehab.
Mobility.
Death.
The end.
Hospital. Hospital. No, we're in a hospital.
I know, but you want one word to describe a hospital. Healthcare.
Okay, pharmaceuticals. Not just description, the first thing that comes to your mind.
Medicine.
Coffee.
Caffeine.
Alcohol.
No more.
No more. Reading.
Wonderful.
Have a final one, tumor.
Challenge.
Awesome. Thank you so much, Dr. Sridhar, for that wonderful, informative session we all had. I'm sure all of you are going to enjoy it. I enjoyed it. And I hope you have more of these informative sessions where people get to learn more about your world and the world of neurosurgery. And like and share and subscribe to this channel because there's going to be too much and more of this content that you're going to get to watch. Bye.